Assalamu alaikum.
This is Dr. Yusuf Sawaf, a neurology demonstrator at King Abdulaziz University. In this video, we will talk about sensory disturbances, اضطرابات الإحساس. Sensory disturbances is an important topic in neurology. Multiple presentations and conditions fall under this category. To be able to fully comprehend the content of this lecture, we have to start from the basics by reviewing some neuroanatomy. Then we will tell you about different categories of sensory disturbances. And finally, we will give you some of the clinical presentations that we face on a day-to-day basis in the clinical practice of neurology. So let's jump back to basics. Before we dive into the details, I just want to remind you that the spinal cord has one descending tract and two ascending tracts. The descending tract is the motor tract, and the ascending tracts are the sensory tracts. The motor is not within the scope of this talk, while the sensory tracts are the core components of the sensory disturbances. Let's start with the first of the ascending tracts, the dorsal column tract. The dorsal column tract is concerned with the function of discriminative touch, the ability to discriminate an object from other objects. بالعربي لو غمضت عين الشخص اللي قدامي وديته قلم في يده وقلت له تعرف على هذا الشيء هيقدر يعرف إنه هذا قلم بخاصية الديسكريميناتيف تاتش اللي جات من الدورسال كولوم تراكت. ولو نفس الشخص اديته في يده مفتاح وهو مغمض عينه هيقدر يعرف إنه في يده هذا مفتاح بالخاصية اللي عنده من الدورسال كولوم تراكت اللي هي discriminative touch. إيش هي ال individual components or the individual features that are resulting in this ability to discriminate objects while closing your eyes through sensation. They are fine touch, vibration, proprioception. في معهم كمان 2-point discrimination. However, just remember those three: fine touch, vibration, and proprioception. These components, together with the 2-point discrimination, would give the person the ability to have discriminative touch, which is basically the function of the dorsal column tract. So let's talk about the anatomy of the dorsal column tract. As we said, it's an ascending pathway. The information starts from the peripheral nerves, and here we have the first order neuron, the afferent neuron. It goes from the skin, where the receptors are, then follows the path of the first order neuron to the dorsal root ganglia, and from there it continues ascending until it reaches the medulla. In the medulla, the lateral aspect of the medulla, the first order terminates and the decussation happens, and you can see it is decussating from the ipsilateral side to the contralateral side in the medial lemniscus. From there, it will continue on the contralateral side until it reaches the thalamus. In the thalamus, we have the end of the second order neuron and the beginning of the third order neuron, which is the last neuron that reaches all the way up to the primary somatosensory cortex. From all of this diagram, I want you to remember the fact that the dorsal column tract decussates in the medulla and not in the spinal cord. Following that, let's talk about the spinothalamic tract. The spinothalamic tract is concerned with the function of crude touch, pain, and temperature. Crude touch, pain, temperature. The anatomy of the spinothalamic tract goes like this. The first order neuron is at the level of the skin, then it ascends, goes through the dorsal root ganglia the same way of the dorsal column tract. Then, as you see, at the level of the spinal cord, this here is the spinal cord. At the level of the spinal cord, you see that it decussates. You see that it decussates at the level of the spinal cord, and from there it goes to the Lissauer's tract. The Lissauer tract, I like to call it the elevator أو الأسانسير. خلينا نرسم لكم هو، مثلا خلينا نقول هنا C6، هنا C5، هنا C4، بعدين هنا right وهنا left. لو افترضنا إنه الفايبر جاية من الليفت سايد دخلت على C6 حتطلع 2 levels إلى C4، بعدين it will decussate and continues all the way to the cortex. So it does decussate, however it goes 2 levels above, then it decussates. Then from there it will continue all the way up, then it will pass through the lateral medulla, the same area where the dorsal column tract would pass, and continue its ascension up until it reaches the thalamus, and from there the second order neuron would finish or terminate, and the third order neuron in the thalamus would originate and reach all the way to the primary sensory cortex. From this diagram, I want you to remember that the first order neuron would decussate at the level of the spinal cord, not at the level of the medulla, like the dorsal column tract, and it does not decussate immediately. It goes 2 levels up before decussation. Those 2 levels up is called Lissauer's tract, or are called Lissauer's tract. You just go up 2 levels, then you decussate. عشان يكون سهل لكم تفتكروها نحب نسميها الأسانسير. So, just a quick reminder, dorsal column, discriminative touch, decussates at the level of the medulla. Spinothalamic, crude touch, pain and temperature, decussates at the level of the spinal cord. The next diagram relevant to neuroanatomy of sensory disturbances is the sensory homunculus. As we showed you earlier, the thalamus would have the third order neuron generating and goes all the way up to the somatosensory cortex. You can see in this sensory homunculus, which is the body's representation in the somatosensory cortex, that the body goes from medial to lateral this way. The most medial would be the foot, and the most lateral would be the face. This is similar to the motor homunculus, with one notable difference, and that is in the motor homunculus, the hand would be the most medial, while in the sensory homunculus, the face would be the most medial. When you have a patient who has a massive stroke that includes the parietal cortex, you will find that all the sensory homunculus would be affected, so it covers from toe to face. However, there might be smaller infarctions that could involve hand to toe, but doesn't include the face, and we will show you examples of that later on.
Diagrams I want to show you before we jump into the types of sensory disturbances. The first is the spinal cord, and I want you to remember that the lumbar cord and the sacral cord terminate at the level of L1 or L2 based on the individual. Then their fibers would go all the way down in the coda equina, and from there they would leave the spinal cord and form the lumbosacral plexus. The final diagram is for the dermatomes of the body, and you can see that there are different levels of the dermatomes. And if we have a sensory disturbance that, for example, reaches to T12 and goes all the way down from T12, anything above that is normal, anything below that is abnormal. We call this a sensory level. So later on, when we talk about a sensory level, you know what we mean by that word. So let's jump to the types of sensory disturbances that we can see in the clinic. The first type is a single nerve lesion. So if we're talking about an ascending pathway, this would be a lesion that in the very beginning of the ascending pathway. For example, in carpal tunnel syndrome, there is pressure on the median nerve and you have a paresthesia only at the distribution of the median nerve. The second type is a polyneuropathy. It is a kind of paresthesia that presents from different nerves being affected at the same time. For example, people who have diabetes classically present with stock and glove paresthesia. Or also, we can have pins and needles paresthesia with people who have B12 deficiency, for example. These are polyneuropathies. These are manifestations of sensory disturbances that include multiple nerves in different locations at the same time. The third type is spinal lesions. Now we are ascending up the tract and we talk about lesions or disturbances that are at the level of the spine, either spinothalamic, dorsal column, or both of them at the same time. As we ascend up the track, we can have lesions at the brainstem level. These are lesions that can be seen at the level of the medulla or pons, for example. These include the second order neuron as it is ascending through the brainstem. The last type is the intracranial lesions. Intracranial lesions are above the level of the thalamus, either in the fibers or in the somatosensory cortex itself. This list of types leads us to this beautiful diagram. This diagram shows us different manifestations of sensory disturbances. The first one, diagram A, is complete hemiparesthesia, hemisensory loss. This is the classic presentation of a contralateral parietal lesion in the brain. A contralateral parietal lesion in the brain. So, for example, this is left-sided hemiparesthesia, and we can expect in the right parietal lobe there is a stroke that is causing this kind of manifestation. The next diagram is a little bit different from diagram A. You can see in diagram B that one side of the body has a paresthesia from the neck all the way down to the foot, while the face would have the opposite side involved. This is a presentation that can be found in lateral medullary syndrome, a stroke that involves the lateral aspect of the medulla. As we told you earlier, The fibers of the spinothalamic tract and the dorsal column tract would ascend upwards, and both of the tracts would pass through the lateral medulla. However, the facial sensations wouldn't be introduced or wouldn't be decussated until the bonds. So the levels below the face, or the fibers coming below the face, have already been decussated, while the face did not decussate yet, or the facial sensations did not decussate yet. They would decussate at the bonds higher than the medulla. That's why you have contralateral body and ipsilateral face. So if we have a right sided lesion, or in this case in this picture it's a left sided, so let's make it left. So if we have a left sided lesion, we will have ipsilateral face and contralateral body. This is only in lateral medullary syndrome. The next diagram is diagram C, and you can see in diagram C that there is a level. This is a sensory level, as I showed you earlier. This is a sensory level, and below this level, all sensations are affected on both sides. This is called paraparesthesia, and it is the result of a complete cord cut. When there's a complete cord cut, you will have paraparesthesia from that level and downwards. Diagram D has a unique shape to it. It involves the hand, arms, forearms, and you can see also the shoulders and the chest on both sides being involved. ممكن تتخيل انه الشخص اللي في دايجرام دي لابس شال في البرد، فالشال هذا مغطي يده والفور ارم والارم وكتفه وصدره. This is the result of a unique condition called syringomyelia. Syringomyelia is an inflammation that comes in the cervical spine, ويدينا هذا type of sensory disturbance. Diagram E is the stock and glove polyneuropathy. Stock and glove polyneuropathy is famous among people who have diabetes. Diagram F is another peculiar diagram. In diagram F, we have dissociated sensory loss. What does dissociated means? It means that on the right side we lose a function, and on the left side we lose a different function altogether. يعني مثلا في اليمين الشخص فقد discriminative touch، while في اليسار الشخص فقد crude touch, pain and temperature. How does that happen? It happens by understanding the anatomy. لو تفتكروا قلنا لكم إنه crude touch, pain and temperature, it decussates at the level of the spinal cord, while the discriminative touch would decussate at the level of the medulla. يعني لو جيت على شخص and you stab the person and resulted with your stab in a complete hemisection of the spinal cord، يعني قطعت له نص السباينال كورد، النص اللي على اليسار سليم تماما، بينما النص اللي على اليمين صار له complete destruction. This injury would result in the following: a dorsal column tract يمشي في اليمين all the way up to the medulla، بعدين يسوي decussation. dorsal column tract ipsilaterally on the same side of the lesion would be affected. A spinothalamic tract decussates at the level of the spinal cord. So these fibers that you have injured with your stab were supposed to decussate on the opposite side. So you expect that you will have this lesion manifesting with left-sided loss of pain, temperature, and crude touch. I told you earlier about Lissauer's tract and that there are two level differences between the entry of the fiber and its decussation. I will not go into the details, I'll just leave it for you to think about it. However, this kind of manifestation, when you have dissociated loss of discriminative touch and crude touch and pain and temperature, it has a name. We call it Brown-Séquard syndrome, and it is the result of hemisection of the cord. Diagrams G and H are the results of dermatomal radiculoneuropathies. Basically, these are lesions at the cord or around the cord. Most likely, you have already covered those kinds of lesions in your neurosurgery rotation. This table has a summary of the patterns of sensory loss. You can go through them on your own time and study each column one by one. I just want to note two types that I did not cover in this lecture. The first one is quadriparesthesia. It is very similar to paraparesthesia. Here in C, we saw paraparesthesia, where there was a lesion that had a sensory level. It included both lower limbs, and this is paraparesthesia. However, if there is a lesion at the cervical level, cervical cord level, it will have a sensory lesion, sensory levels, and it will include the arms in both sides, and it would include the lower limbs on both sides as well. So if the lesion occurs at C cord, the cervical cord, it will cause quadriparesthesia. However, if it happens at the T or the L, the thoracic or the lumbar cords, it will have paraparesthesia. And the last one is distal to proximal. I did not cover this pattern. It is when the sensory loss starts from the foot and starts ascending all the way up. This particular pattern is seen in Guillain-Barré syndrome. Guillain-Barré syndrome has a separate lecture in which we will cover it in much more detail. That's why I did not discuss it whatsoever in this particular video. All the other patterns in this table have already been covered in this lecture. The possible localizations, go through the possible localizations. They will make sense to you based on all the anatomy we reviewed in this lecture. And the notes on what you would find in your examination would also make sense based on the anatomy. This concludes our lecture on sensory disturbances. Feel free to go through the materials as many times as you want. Write down any questions you have. If you have any concept you would want us to re-explain to you, we will have a live session scheduled where you can ask your questions or ask us to explain any concept again to you. I wish you all the best and good luck.